Welcome to The Explainer. Today we're breaking down a condition that every single one of us sees in clinical practice, acute cystitis. We're going to walk through a very clear clinical pathway all the way from diagnosis right through to management. So here's our game plan for today. We'll start by defining the disease itself, then we'll get into pathogen identification and testing. After that, we'll cover both adult and pediatric treatment protocols, look at potential complications, and we'll wrap things up with a quick clinical case challenge. All right, first things first, what exactly is acute cystitis? And just as importantly, how do we distinguish it from other conditions that can look suspiciously similar? At its core, acute cystitis is simply an inflammation of the urinary bladder. The clinical presentation is often that classic triad of symptoms: dysuria, or painful urination, pollakiuria, which is that constant feeling of needing to urinate, and that nagging lower abdominal pain. You might even get clues from cloudy or frankly foul-smelling urine. But here is an absolutely critical first step. You have to rule out the mimics. Urethritis, for example, can present with symptoms that are nearly identical. That's why specific diagnostics, like vaginal NAATs for STIs, are often essential. And with pelvic inflammatory disease, or PID, while it also causes lower abdominal pain, a key differentiator to look for is pain that gets worse with ambulation, or walking. So, once you have a strong suspicion of cystitis, the next move is to nail down the specific pathogen. Getting this right is truly the cornerstone of effective therapy and, of course, good antibiotic stewardship. The diagnostic pathway here is actually pretty straightforward. You start with a good, clean specimen, washed midstream urine, or a single catheterization. Your initial screening is the urine dipstick. A positive nitrite result is a big flag that tells you to investigate further. But for the definitive answer, especially if there are systemic symptoms, you really need to get a culture with susceptibility testing. And please don't forget those STI diagnostics if urethritis is even a remote possibility. So who are the usual suspects? Well, the microbial landscape is overwhelmingly dominated by one organism, E. coli. It's the culprit in about half of all cases. This fact is so important because it heavily informs our first-line antibiotic choices, often before we even get the culture results back. And this chart right here is exactly why knowing your local resistance patterns is so critical. Our first-line drugs like nitrofurantoin and fosfomycin still have incredibly low resistance rates for E. coli, hovering around just 2%. But look at an older antibiotic like trimethoprim, resistance is now up around 20%. That means it fails in 1 out of every 5 cases. This data makes our empirical choice crystal clear. You know, with the way bacterial resistance is constantly evolving, sometimes you have to wonder if they're doing it on purpose. Perhaps E. coli just wants to keep the microbiologists on their toes. Okay, so armed with all that diagnostic data, let's pivot and talk about the evidence-based treatment protocols for our adult patient population. Treatment absolutely must be tailored to the specific pathogen and its sensitivities. For your standard E. coli, a 5-day course of nitrofurantoin is perfect. But if that culture comes back showing enterococcus, you need to switch gears to amoxicillin. And in those much rarer fungal cases caused by candida, you're in a whole different ballpark, looking at a much longer 14-day course of an antifungal like fluconazole. Now, this is a critical point to remember. Cystitis in men is automatically considered a complicated infection. It almost always points to an underlying prostatitis, which means you have to manage it as such, following specific and usually much longer prostatitis treatment protocols. Now, let's shift our focus to the pediatric population, because treating children comes with its own very distinct set of rules and risks. The approach in kids really hinges on whether the infection is just in the bladder or has moved up. For simple cystitis, a very short course of nitrofurantoin, just 2 to 4 days, is often enough. But, and this is a big but, if it has progressed to pyelonephritis, a kidney infection, you have to treat far more aggressively to prevent permanent renal scarring. That means a longer 10 to 14-day course of a broader agent, and you might even need to consider IV antibiotics for a severely ill child. Failing to treat cystitis properly or in a timely manner can have some really serious consequences. Let's take a look at the risks of letting this infection progress. An untreated bladder infection can kick off a truly dangerous chain reaction. It can ascend to the kidneys, causing pyelonephritis. In men, it can spread locally, leading to epididymitis or prostatitis. And the worst-case scenario for any of these pathways is the same: the onset of sepsis. And the stakes, when you get to sepsis, are terrifyingly high. We're talking a mortality rate between 30 and 50%. That number alone is a stark reminder of why prompt, effective treatment for what might seem like a simple UTI is completely non-negotiable. All right, to wrap all this up, let's apply everything we've covered in a quick clinical case challenge.
So consider this case. A 28-year-old, non-pregnant woman comes in with the classic signs of uncomplicated cystitis, and her dipstick is positive for nitrates. Based on the likely pathogens and those resistance patterns we just talked about, which one of these options is the most appropriate first-line oral antibiotic?
The correct answer here is C, nitrofurantoin. It's the recommended first-line agent for this exact clinical scenario because it is highly effective against our number one suspect, E. coli, and it has that well-established low resistance rate. An agent like ciprofloxacin is not a first-line choice for uncomplicated cases. We need to reserve it to combat resistance. Animoxidil and azithromycin are really for specific pathogens or suspected STIs, not this presentation. So after all of that, what's the ultimate takeaway? It is this: precise diagnosis, one that is guided by culture and susceptibility data, is not just some academic exercise. It is the absolute foundation of effective and responsible antibiotic stewardship in managing acute cystitis. It's how we get the treatment right for our patients, and it's how we protect these crucial therapies for everyone in the future.